In October 1347, 12 Genoese galleys docked at the Sicilian port of Messina. They carried a cargo that would liquidate half of Europe's population in less than 5 years. The sailors were mostly dead. Those still alive were covered in black, oozing boils that smelled of death. This was not merely a sickness. It was a biological annihilation. From the moment of infection, the human body began to decompose while the victim was still breathing. This is the anatomical reality of the Great Mortality. The arrival of the plague in Europe marks the most significant demographic collapse in recorded human history. To understand the sheer scale of the devastation, one must look beyond the statistics and examine the biological degradation of the individual human host. The causative agent, a gram-negative bacterium known as Yersinia pestis, waged a total war on the human immune system, manifesting in 3 distinct forms: bubonic, pneumonic, and septicemic. The trajectory of the disease, from infection to termination, presents a study in physiological horror. The mechanism of infection typically began with the bite of a flea, Xenocilla chiopes, which had regurgitated the bacteria into the human bloodstream after its own gut had become blocked by the multiplying pathogen. Once inside the human host, the bacteria traveled to the nearest lymph nodes, usually in the groin, axilla, armpits, or neck. This migration marked the beginning of the incubation period, a deceptive window of 2 to 6 days where the host remained asymptomatic, unknowingly serving as a reservoir for the pathogen. The onset of symptoms was sudden and violent. The patient would experience strictly physical manifestations: rigor, high fever reaching 104 degrees Fahrenheit, and severe joint pain. However, the defining clinical feature of the disease appeared shortly after the bubo. The lymph nodes, overwhelmed by the bacterial replication, would swell into large, hard tumors. These swellings ranged in size from an almond to an egg, and in extreme cases, the size of a common apple. The buboes were exquisitely painful. The slightest touch or pressure caused agony described in contemporary chronicles as maddening. The skin stretched over these tumors, initially red, would turn a dark, bruised purple, and eventually black as the tissue began to die. The internal devastation was equally catastrophic. As the infection spread, it attacked the vascular system. Capillaries would rupture beneath the skin, causing distinct hemorrhaging known as petechiae. These subsurface pools of blood would darken, creating the black spots that gave the Black Death its name. This was necrosis, the premature death of cells in living tissue. The body was effectively rotting from the inside out. In the septicemic variant, the bacteria multiplied directly in the bloodstream, leading to disseminated intravascular coagulation, DIC. The patient's extremities, fingers, toes, and nose, would turn necrotic and gangrenous, blackening and dying while the patient remained conscious. The smell emitting from the patient was described as overwhelmingly putrid, the scent of decomposing meat emanating from a living organism. In the pneumonic variation, the pathogen settled in the lungs. This was the most lethal and contagious form. The physiological breakdown here involved the liquefaction of lung tissue. Patients would develop a severe cough, expectorating bright red, frothy blood mixed with pus. Respiration became labored and gurgling as the lungs filled with fluid, effectively drowning the patient in their own blood. The mortality rate for the pneumonic plague was nearly 100%, with death occurring within 24 to 48 hours of the first symptom. Medieval medicine, operating under the Galenic theory of humorism, was wholly unequipped to address a bacteriological pathogen. However, the attempts to treat the symptoms were physically invasive and often exacerbated the patient's suffering. Physicians, believing the buboes contained the concentrated poison of the disease, attempted to draw it out through surgery. The most common surgical intervention involved the lancing of the buboes. A physician would use a scalpel to slice open the swollen lymph node. This procedure was performed without anesthesia. Upon incision, a mixture of blood, necrotic tissue, and thick, foul-smelling pus would erupt from the wound. The physician would then cauterize the open wound with a red-hot iron to stop the bleeding and, theoretically, burn away any remaining infection. This process often led to secondary infections, septic shock, or death from blood loss. Another prevailing theory was that the disease was caused by an imbalance of body fluids. To correct this, aggressive phlebotomy or bloodletting was employed. Veins in the arm, neck, or foot were opened to drain corrupted blood. For a patient already suffering from severe dehydration, fever, and internal hemorrhaging, the deliberate removal of blood merely accelerated the onset of cardiac arrest. Topical applications were also utilized based on the principle of sympathy or drawing. A common treatment involved the Vickery method. A live chicken would be plucked of its feathers around the anal vent and strapped directly to the plague bubo. The belief was that the bird would draw the poison out of the human and into itself. When the chicken died, usually from the toxicity or suffocation, it would be replaced by another, continuing the cycle until the patient either recovered or, more likely, expired. More caustic treatments included the application of blistering agents. Pastes made from resin, roots of white lilies, and dried human excrement were applied to the open sores. The logic was that the virulence of the excrement would pull the pestilence from the body. In reality, introducing fecal matter to open necrotic wounds guaranteed lethal bacterial superinfections. For those suffering from the intense headaches and delirium associated with the high fever, trepanation was occasionally suggested in extreme desperation. This involved drilling a hole into the skull to relieve the pressure of the bad air or vapors believed to be trapped within the cranium. If the plague did not kill the patient, the trauma of cranial surgery in a septic environment certainly would. The final stage of the disease for the terminal patient was a descent into total physiological collapse. The vital organs, deprived of oxygen and poisoned by septicemia, shut down one by one. The patient would slip into a coma or experience terminal delirium before cardiac cessation. The speed of the contagion meant that bodies accumulated faster than they could be buried. The decomposition process, accelerated by the nature of the disease, meant that corpses bloated and ruptured rapidly, contributing to the miasma that hung over European cities. The medical response to the Black Death highlights the utter helplessness of medieval science against a high-mortality pathogen. Every intervention, from lancing to bloodletting, was a physical assault on a body already fighting a losing war against biological disintegration. The silence that followed the plague years was not merely a silence of mourning, but a silence of a population biologically culled by a microscopic predator they could not see, could not understand, and could not fight. If the Black Death was a sudden, violent explosion that decimated Europe, leprosy was a slow, creeping erosion. It was known as the living death. For the medieval mind, leprosy was not merely a biological infection. It was an external manifestation of internal sin, a purgatory suffered on earth. Caused by the bacillus mycobacterium leprae, this chronic granulomatous disease primarily targeted the skin, the peripheral nerves, the mucosa of the upper respiratory tract, and the eyes. Unlike the plague, it did not kill quickly. Instead, it dismantled the human form piece by piece over decades, trapping the victim in a decaying prison. The biological onset of leprosy is insidious. The bacteria replicate strictly within the cooler parts of the body, the skin, extremities, and nasal cavities. The first sign was often a simple, painless patch of discolored skin. However, the true horror lay in the neurological damage. The bacteria attacked the Schwann cells, which insulate the nerves. This resulted in profound anesthesia, a total loss of sensation. A leper could burn their hand in a fire, step on a rusted nail, or have their flesh gnawed by rats while sleeping, yet feel absolutely nothing. This lack of pain was not a mercy. It was the catalyst for the severe mutilation associated with the disease. Without the warning signal of pain, injuries went untreated, leading to secondary infections, gangrene, and tissue loss. As the disease progressed to the lepromatous stage, the physical transformation became grotesque. The bacteria formed nodular lesions or granulomas across the face. The skin thickened and folded, the eyebrows and eyelashes fell out, and the earlobes swelled and elongated. This specific disfigurement was medically termed facies leonina, or lion face. The human visage was erased, replaced by a coarse, animalistic mask. The destruction continued internally. The mucous membranes of the nose were ravaged, causing the nasal septum to collapse. This resulted in the characteristic saddle nose deformity, leaving the victim with a flattened, cratered cavity in the center of their face. The voice changed, becoming hoarse and raspy as the larynx was infiltrated. In the extremities, a process known as autoamputation occurred. The body did not simply drop limbs. Rather, due to repeated trauma and bone resorption, osteolysis, the fingers and toes would shorten, curl into claws, and eventually be absorbed back into the hand or foot, leaving behind useless, club-like stumps. Because medicine could not cure the disease, society turned to segregation. The diagnosis of leprosy carried a legal and spiritual death sentence. Once a person was declared a leper by a physician or a priest, they were subjected to the messa ad exclusionum leprosi, the mass of separation. This was, for all intents and purposes, a funeral service for a living person. The afflicted individual was brought to the church, draped in a black funeral shroud. They would kneel before the altar while the requiem mass was sung. The priest would then lead them to the churchyard, where an open grave awaited. The leper would stand in the grave, and the priest would toss a spade of earth onto their feet, symbolizing their burial. From that moment on, they were legally dead. Their property was confiscated or passed to heirs, their marriage was effectively annulled, and they were banished from the community. The restrictions placed upon the leper were absolute. They were forbidden to enter inns, churches, mills, or bakehouses. They could not touch children or speak to anyone unless they stood downwind, to prevent their corrupt breath from carrying the infection. To navigate the world, they were forced to wear distinctive clothing, often a gray cloak and a hood to hide their face, and carry a wooden clapper or a bell. The sound of this instrument was a warning signal, a sonic barrier that announced their unclean presence, compelling healthy citizens to flee their path. Medieval medical treatments for leprosy were a mixture of desperation, superstition, and cruelty. Since the disease was associated with melancholic or thick, cold humors, treatments aimed to heat and purify the blood. Phlebotomy, bloodletting, was standard, performed from veins under the tongue or behind the ears, believing this would drain the corrupt blood from the head. Dietetic restrictions were severe. Lepers were forbidden from eating cold foods like fish or hare, and were prescribed snake meat. The viper, a creature that shed its skin, was believed to possess regenerative properties. Physicians concocted theriac of vipers, a thick paste made from snake flesh, opium, and honey, which the patient was forced to consume. Topical treatments involved caustic ointments containing arsenic, hellebore, and sulfur, applied directly to the open sores. In some recorded instances, more macabre remedies were sought. Influenced by misinterpretations of ancient texts, some wealthy lepers believed that bathing in the blood of virgins or infants could purify their skin, a horrific practice that, while rare, underscored the sheer terror the disease inspired. More commonly, the leper was condemned to a lazar house or leprosarium. These institutions, located on the outskirts of towns, were less hospitals and more warehouses for the dying. Here, surrounded by the smell of gangrene and the sounds of suffocated breathing, the leper awaited the end. The conditions were squalid, with little medical oversight. The care was palliative at best, usually administered by monks who washed the sores and offered prayers, waiting for the infection to finally overwhelm the body's vital organs or for secondary diseases like tuberculosis to finish what the leprosy had started. Leprosy stands as a testament to the fragility of the human condition in the Middle Ages. It stripped the victim not just of their health, but of their identity, their humanity, and their place in the world. To be a leper was to be a ghost haunting the edges of civilization, watching life continue from behind a veil, trapped in a body that was slowly consuming itself. While the Black Death was a catastrophic wave and leprosy a slow sentence of isolation, smallpox was a constant, endemic presence in medieval Europe. Known variously as the Red Plague or the Speckled Monster, it was a viral pathogen variola major that became an inevitable rite of passage for the population. In an era before vaccination, nearly everyone eventually contracted it. The disease was particularly ruthless toward children, accounting for a staggering percentage of infant mortality, and it left its survivors permanently branded. The transmission of variola major was terrifyingly efficient. It spread primarily through respiratory droplets expelled from the mouth or nose of an infected person, or through direct contact with the contaminated bedding or clothing of a patient. Unlike the plague, which relied on vectors like fleas, smallpox required only human proximity. Following inhalation, the virus entered a silent incubation period of approximately 12 days, replicating invisibly within the host's lymphatic system before launching a systemic assault. The clinical onset was sudden and violent. The initial symptoms, the prodrome, resembled a severe influenza but with intensified brutality. High fever soaring above 104 degrees Fahrenheit 40 degrees Celsius, debilitating headache, severe back pain, and projectile vomiting. The patient would be rendered prostrate, enduring days of agony before the defining feature of the disease appeared. Around the fourth day of fever, the rash began. It started not on the skin, but in the mucous membranes of the mouth and throat, enanthema. These internal lesions would rupture, releasing high concentrations of the virus into the saliva, making the patient highly infectious. Simultaneously, the external rash, exanthema, appeared, first on the face and forearms, then spreading centrifugally to the trunk and legs. The evolution of these lesions was slow and excruciating. They began as flat red spots, macules, raised into hard bumps, papules, and then filled with clear fluid, vesicles. By the second week, these vesicles turned into pustules, deep-seated, firm, and intensely painful blisters filled with thick, opaque, yellowish pus. Unlike chickenpox blisters, which are superficial, smallpox pustules felt like small lead shot embedded deep within the dermis. In severe cases, classified as confluent smallpox, the pustules were so numerous that they merged, forming large, continuous sheets of pus across the body. The skin, unable to contain the pressure, would detach from the underlying flesh. The patient's face would become unrecognizable, swollen into a grotesque, featureless mask of purulent matter. The smell was described as sickeningly sweet, the odor of rotting flesh emanating from a living body. Even more lethal were the hemorrhagic variants, known as black pox. In these cases, the virus destroyed the vascular integrity of the skin and internal organs. The pustules would fill not with pus, but with blood. The skin turned deep purple or black as hemorrhaging occurred beneath the surface. Patients bled from the gums, eyes, and nose, usually dying from massive internal bleeding and multi-organ failure before the rash even fully matured. For those who survived the pustular phase, the ordeal was not over. Over the course of the third and fourth weeks, the pustules would rupture, drain, and dry into thick, dark scabs. The itching during this phase was maddening. Patients, particularly children, would tear at their skin, introducing secondary bacterial infections like staphylococcus, leading to cellulitis, sepsis, or gangrene of the affected areas. The aftermath of smallpox was permanent. When the scabs fell off, they left behind deep, pitted depressions in the skin, pockmarks, formed by the destruction of sebaceous glands and hair follicles. The face, being the most heavily affected area, was often left severely scarred. Furthermore, if pustules had formed on the cornea of the eye, the resulting ulceration led to permanent blindness. A significant portion of the medieval blind population owed their condition to variola major. Medieval medical responses to smallpox were largely based on sympathetic magic and flawed humoral theories. The viral nature of the disease was completely unknown. The most famous and bizarre treatment was the red cure, championed by physicians like John of Gadsden in the 14th century. Based on the observation that the rash was red, it was believed that the color red held sympathetic healing properties and could prevent scarring. Patients were wrapped in red blankets, placed in rooms draped with red hangings, and forced to consume red foods and drinks. While psychologically comforting perhaps, this phototherapy had zero effect on the viral replication. Other treatments were actively harmful. To address the humor imbalance, physicians employed bleeding and purging, further weakening a body already ravaged by fever and dehydration. Topical applications aimed at preventing scarring were equally dubious. Concoctions containing animal fats, excrement, or caustic herbs were applied to the face, often causing terrible secondary infections in the open sores. Some physicians advocated for the lancing of pustules with gold. Smallpox in the Middle Ages was an inescapable biological tax on humanity. It did not discriminate by class, scarring kings and peasants alike. It was a disease that not only killed but deconstructed the human face, leaving its survivors visibly marked by their encounter with the speckled monster, living testaments to a viral predator against which medieval medicine was entirely impotent. While plague and smallpox were episodic terrors, dysentery, known colloquially in the Middle Ages as the bloody flux, was a constant, grinding attrition. It was the quintessential disease of poor sanitation, thriving in crowded urban centers and, most devastatingly, in military encampments. Historians estimate that throughout medieval warfare, dysentery killed far more soldiers than swords or arrows ever did. It was a disease of filth, transmitted via the fecal-oral route, where the ingestion of water or food contaminated with infected fecal matter initiated a catastrophic breakdown of the human digestive tract. The causative agents were primarily bacterial, most notably species of Shigella, though amoebic dysentery, Entamoeba histolytica, also occurred. Upon ingestion, these pathogens survived the acidic environment of the stomach and colonized the large intestine, colon. There, they invaded the epithelial cells lining the gut mucosa. The bacteria multiplied rapidly within these cells, releasing potent cytotoxins, such as the Shiga toxin, which inhibited protein synthesis and caused massive cellular death. The clinical manifestation was horrific and rapid. The incubation period was short, often just 1 to 3 days. The first symptom was usually a sudden onset of high fever and agonizing abdominal cramping, tenesmus, described by contemporaries as a feeling of hot iron hooks tearing at the bowels. This was quickly followed by the defining characteristic of the disease: voluminous, explosive diarrhea. Initially, the stool was watery and feculent. However, as the bacterial toxins ravaged the intestinal lining, destroying the mucosa and submucosa, the nature of the excretion changed dramatically. The inflammation caused ulcers to form along the colon wall, which would bleed profusely. The patient began to pass stool that consisted almost entirely of blood, mucus, and necrotic tissue, pieces of the sloughed-off intestinal lining itself. The frequency of bowel movements became relentless, sometimes exceeding 20 or 30 times in a single day. The physiological impact on the body was one of profound and rapid depletion. The relentless diarrhea led to severe dehydration and catastrophic electrolyte imbalances. The loss of vital fluids and salts, sodium, potassium, caused extreme fatigue, muscle cramps, sunken eyes, dry skin that lost its elasticity, and a rapid, weak pulse. The patient's body temperature, initially high due to the infection, would often plummet in the terminal stages as shock set in. In severe cases, the toxic megacolon could occur, where the colon became grossly distended and paralyzed. This could lead to perforation of the bowel wall, spilling infectious contents into the abdominal cavity and causing lethal peritonitis. Death usually resulted from a combination of hypovolemic shock due to massive fluid and blood loss, systemic toxemia, and sheer physical exhaustion. The victim literally defecated themselves to death, often lying in their own filth, too weak to move. The medieval environment was a perfect incubator for dysentery. In cities, open sewers ran through streets, and cesspits leaked into wells used for drinking water. But the conditions in military camps were the apotheosis of filth. Thousands of men and animals lived in close quarters with inadequate latrines. Human and animal waste contaminated the ground and nearby water sources. A single infected soldier could contaminate the water supply for an entire army. Chronicles of campaigns, such as King Henry V at Agincourt in 1415, are replete with accounts of the flux devastating the ranks, forcing armies to halt or retreat not because of enemy action, but because the soldiers were too weak to stand or hold a weapon. Medieval medicine was largely powerless against this bacterial onslaught. Treatments were empirical and often counterproductive, based mostly on the Galenic principle of opposites. Since the disease was characterized by flux or excessive flow, remedies aimed to be binding or constipating. Physicians prescribed diets of dry, binding foods, hard biscuits, roasted meats, and rice, if available. They administered herbal concoctions containing tannins, which have mild astringent properties, such as oak bark, blackberry roots, or pomegranate rinds. Opium, derived from poppies, was highly valued for its ability to slow peristalsis and dull the agonizing pain, providing symptomatic relief though doing nothing to address the underlying infection. Conversely, and dangerously, some physicians adhered to the theory that the body needed to be purged of the peccant humors causing the sickness. They would administer strong purgatives, laxatives, or perform phlebotomy, bleeding. For a patient already dying from dehydration and blood loss, these treatments were tantamount to medical execution, accelerating the path to fatal shock. Other remedies bordered on the sympathetic or magical, wearing certain amulets or consuming powdered precious stones, like coral or pearls. Mixed with wine were remedies reserved for the wealthy, offering false hope in exchange for gold. Dysentery in the Middle Ages was a brutal leveler. It was a disease stripped of any romanticism, a squalid and humiliating end that reduced kings, knights, and peasants alike to a state of absolute physical wretchedness. It was a stark reminder that in an age before sanitation and antibiotics, the greatest threat to human life often came not from a grand external enemy, but from the microscopic consequences of daily existence. While plague, leprosy, and smallpox were transmissible agents passed from human to human, the horror known as Saint Anthony's fire, ignis sacer, originated from the very source of medieval sustenance, bread. It was a mass poisoning caused by the ingestion of Claviceps purpurea, a parasitic fungus that infects rye grain. In cool, damp summers, this fungus replaced the rye kernels with black, spur-like sclerotia known as ergot. When milled into flour and baked into the dark bread that formed the staple diet of the peasantry, these fungi released a cocktail of toxic alkaloids, most notably ergotamine. The result was a devastating mycotoxicosis that manifested in two distinct and terrifying forms: gangrenous and convulsive. The pathology of the gangrenous form was a study in vascular constriction. The alkaloids acted as potent vasoconstrictors, clamping down on the capillaries and arterioles in the extremities. This effectively cut off blood supply to the fingers, toes, hands, and feet. The sensation described by victims was an intense, unbearable burning, as if their limbs were being consumed by invisible flames, hence the name holy fire. Following the initial burning paresthesia, the affected limbs would turn cold and pale. As tissue death, necrosis, set in, the color shifted to a deep, mummified black. This was dry gangrene. The most disturbing aspect of this pathology was the process of autoamputation. The dead tissue would shrivel and eventually detach from the healthy body. Entire fingers, toes, and even whole feet or legs would simply drop off, often without any bleeding, as the vessels were tightly constricted. It was not uncommon for a sufferer to wake up and find a detached foot lying in their bed. Victims were literally falling apart while still alive, carrying their blackened, severed limbs to shrines as offerings. The convulsive form of ergotism presented a different kind of horror, targeting the central nervous system. The toxins induced violent, involuntary muscle spasms and seizures. Victims would be contorted into impossible, painful postures, their bodies racked by tremors. This physical agony was accompanied by profound mania and psychosis. The alkaloids in ergot are chemically related to LSD, lysergic acid diethylamide, causing potent hallucinations. Sufferers saw demons, hellfire, and terrifying beasts attacking them. Entire villages could be plunged into mass hysteria, with residents screaming, convulsing, and hallucinating collectively. A scene often misinterpreted by the church as demonic possession or divine punishment. The social response to this affliction centered on the Order of Saint Anthony. Founded in the late 11th century, the Antonine monks established hospitals specifically dedicated to treating victims of the holy fire. Their primary method of treatment, though they did not understand the chemistry behind it, was surprisingly effective. They changed the patient's diet. By admitting patients to the hospital and feeding them wheat bread, which is resistant to ergot fungus, instead of their usual infected rye bread, the intake of toxins ceased. The vasoconstriction would slowly relax, and if the gangrene had not progressed too far, the burning sensation would subside. To soothe the excruciating pain of the necrotic limbs, the monks applied St. Anthony's balsam, a salve made from lard, pork fat, and medicinal herbs. The cooling effect of the lard provided temporary relief from the fire consuming their flesh. However, for those in advanced stages, the only recourse was surgical amputation. The Antonine hospitals became expert centers for amputation. Surgeons would slice through the remaining dead tissue and saw through the bone to remove the gangrenous limb, cauterizing the stump to prevent secondary infection. Chronicles describe hospitals where the walls were lined with the withered, blackened limbs of survivors, hung as macabre votive offerings to the saint in gratitude for halting the disease. St. Anthony's fire was a unique medieval nightmare because it turned the Eucharist, the daily bread, a symbol of life and religious salvation, into an agent of death. It struck the poor almost exclusively, as the wealthy ate white wheat bread and avoided the contaminated rye. It was a disease of poverty and climate, a chemical catastrophe that maimed bodies and broke minds, leaving behind a population of amputees and traumatized survivors who had physically felt the fires of hell while walking on earth. Of all the maladies that afflicted the medieval and early Renaissance world, none was as rapid, as mysterious, or as selective as the sweating sickness, known in medical Latin as sudor anglicus or the English sweat. Unlike the plague or smallpox, which were established recurring scourges, the sweating sickness appeared seemingly out of nowhere in 1485, decimated the population in 5 distinct, terrifying waves, and then vanished from history, leaving modern epidemiology with an unresolved etiological enigma. Its defining characteristic was its pathological velocity. It was the only disease where a man could be perfectly healthy at breakfast and dead by noon. The disease first materialized in the army of Henry Tudor, later King Henry VII, shortly after the Battle of Bosworth Field. Unlike other medieval diseases that thrived on filth and primarily targeted the malnourished poor, the sweating sickness displayed a peculiar predilection for the wealthy, the well-fed, and the upper classes. It struck young, healthy men in the prime of their lives, sparing the elderly and children. This led to it being dubbed the scourge of the rich, tearing through the courts of kings and the halls of universities. The clinical progression of the sickness was distinct and violent, typically unfolding in 2 contrasting stages over a period of mere hours. The first stage was the cold phase. The onset was abrupt. The victim would be seized by a sudden, overwhelming sense of dread and apprehension, a psychological premonition of death. This was immediately followed by violent shivering, vertigo, headache, and severe pains in the neck and shoulders. The extremities turned cold and blue, similar to the chill stage of malaria, but with a far more rapid intensity. The abdominal pain was excruciating, often described as a grief in the stomach. This phase lasted roughly 30 minutes to 3 hours. Then came the hot phase, the hallmark of the disease. The body temperature skyrocketed, and the patient began to sweat profusely. This was not ordinary perspiration. It was described as a fetid, copious flow that soaked through bedclothes and mattresses. The fluid loss was catastrophic. The sweat possessed a distinct, foul odor, described by contemporary physician John Caius as a corrupt and rotten vapor. During this phase, the patient experienced intense thirst, delirium, and a rapid, palpitating heart, tachycardia. The neurological impact was severe. Victims became incoherent or manic. However, the most dangerous symptom was an overpowering, irresistible urge to sleep. Physicians and caretakers knew that to yield to this urge was a death sentence. The maxim of the time was clear: if he sleeps, he dies. Those who drifted into unconsciousness during the sweating phase slipped into a coma and never woke up, likely due to cerebral edema or extreme dehydration-induced shock. The mortality rate was staggering. In some towns, 50% of the population died within a few days. The speed of the disease meant there was no time for the traditional progression of medical care. A person might be walking down the street, feel the sudden tremor of the cold phase, and be a corpse within 4 hours. This hyperacute nature suggests a viral hemorrhagic fever or perhaps a hantavirus pulmonary syndrome, though no definitive pathogen has ever been identified from exhumed remains. Medical treatments were frantic and largely supportive, as there was no time for complex apothecaries. The primary strategy was the moderation of heat. Physicians believed the patient had to sweat out the poison but shouldn't be overheated. They were put to bed and covered with moderate layers. If they were outdoors, they were told to lie down immediately, fully clothed. The most crucial aspect of treatment was keeping the patient awake at all costs. Attendants would shout at the patient, shake them, or even beat them to prevent the fatal slumber. Some treatments involved greasing the patient to encourage more sweating, or administering cordials of herbs like sage and rue to support the heart. However, given the speed of the infection, most interventions were futile. The psychological impact of the sweating sickness was unique. It created a specific type of panic because of its randomness and speed. During the epidemics, life in London and Oxford would come to a standstill. The universities closed, the royal court fled to the countryside, and the streets emptied. The fear was amplified by the fact that surviving one attack conferred no immunity. Many victims survived the first bout only to be killed by a second or third infection weeks later. Then, as quickly as it arrived, the sweating sickness disappeared. After the final outbreak in 1551, it was never seen again. It remains a medical ghost story. A disease that killed tens of thousands of the English elite, terrified a continent, and then evaporated, leaving behind only grave records and the chilling accounts of a sickness that could extinguish a human life in the time it took to cook a meal. While modern history often remembers tuberculosis as consumption, a romanticized disease of the lungs that caused poets to fade away in pale beauty, the medieval manifestation was far more grotesque. Known as scrofula or the king's evil, it was a form of tubercular adenitis caused by the same pathogen, Mycobacterium tuberculosis, or often the bovine variant, M. bovis, transmitted through infected cow's milk. Instead of merely consuming the lungs, this variation attacked the lymphatic system, specifically the cervical lymph nodes in the neck, creating a visible and repulsive external deformity. The etymology of the word scrofula offers a grim insight into the physical appearance of the victims. It is derived from the Latin scrofa, meaning breeding sow. The disease caused such massive swelling in the glands of the neck that the patient's face was pushed upward and distorted, giving them a pig-like appearance. The pathological progression was slow but relentless. The bacteria would colonize the lymph nodes, causing them to inflame and harden. Over time, these hard knots would soften as the tissue within them succumbed to caseous necrosis. a form of cell death where the tissue turns into a cheese-like white, crumbly mass. Eventually, the skin covering these abscesses would thin, turn purple, and rupture. This resulted in chronic, draining sinus tracts, open wounds on the neck that continuously leaked a thick, curdy pus. These sores resisted healing, often remaining open for years, forming crusty scabs that would peel away to reveal the raw, weeping flesh beneath. Because the infection was systemic, it often spread to the bones and joints, Pott's disease, causing the spine to collapse and leaving the victim with a severe hunchback, further adding to the social stigma of physical deformity. Medieval medicine offered no effective cure for this bacterial invasion. Surgical removal of the infected glands was attempted, but it was a perilous operation. The neck is a region dense with major blood vessels and nerves. A slip of the surgeon's knife could sever the jugular vein or the carotid artery, leading to immediate death by exsanguination. Even if the surgery was successful, the unsterilized instruments usually reintroduced infection, leading to sepsis. In the absence of a medical solution, the population turned to a supernatural one. This gave rise to one of the most enduring and bizarre socio-medical rituals in European history, the royal touch. It was a widely held belief, sanctioned by the Church and the Crown, that the kings of England and France possessed the divine power to cure scrofula simply by touching the affected area. This belief was rooted in the concept of the divine right of kings, that the monarch was God's anointed representative on earth. The disease thus acquired its colloquial name, the king's evil. Ceremonies were organized on a massive scale. During the reign of King Edward I, or later under Charles II, thousands of scrofula sufferers would gather, waiting for days in crowded, unsanitary conditions for a chance at salvation. The king would systematically touch the open sores and swollen necks of the sick, often washing them with water or wine. After the touch, the patient received a gold coin known as an angel because it bore the image of the archangel Michael, which was hung around their neck as a talisman. The logistics of these ceremonies were staggering. King Charles II is recorded to have touched over 90,000 people during his reign. The irony of the ritual was palpable. The monarch, the symbol of ultimate power and hygiene, coming into direct physical contact with the pus-filled, necrotic wounds of the poorest, most destitute citizens. Scientifically, the cure was non-existent. However, because scrofula is a disease that can have periods of remission where the swelling naturally subsides for a time, these coincidental improvements were hailed as miracles, reinforcing the political power of the king. For the majority, however, the disease was a lifelong sentence of disfigurement. The open sores would eventually scar over into thick, ropey tissue, permanently restricting the movement of the neck. Scrofula represents a unique intersection of pathology and politics. It was a disease where the biological rotting of the human body became a stage for the performance of royal authority. The sick were not merely patients. They were props in a theater of divine power, their festering wounds serving as the validation of the king's right to rule, while they themselves remained trapped in a cycle of chronic pain and decay. If the plague was the disease of the trade routes and dysentery the disease of the war camp, typhus was the disease of confinement. Known colloquially as jail fever, ship fever, or camp fever, it thrived in the darkest, most claustrophobic corners of the medieval world, the dungeons, the holds of ships, and the crowded slums. It was a bacteriological predator that exploited the human inability to wash. Its causative agent was Rickettsia prowazekii, an obligate intracellular parasite, but the architect of its transmission was the human body louse, Pediculus humanus corporis. The mechanism of infection is a testament to the squalor of the era. The louse thrives in the seams of unwashed clothing, feeding on human blood. Contrary to popular belief, the bite of the louse does not directly transmit the disease. Rather, the louse becomes infected by feeding on a typhus carrier. The bacteria multiply in the gut of the louse until they cause the insect's stomach to rupture. The louse then defecates the pathogen-rich feces onto the human skin while feeding. The human host, irritated by the bite, scratches the area, inadvertently grinding the infected louse feces into the open micro-wounds of the bite or into their eyes. Thus, the victim effectively inoculates themselves with the disease. The incubation period lasts 1 to 2 weeks, a ticking clock while the bacteria infiltrate the endothelial cells lining the small blood vessels. The onset of symptoms is abrupt and catastrophic. The patient is struck by a severe, intractable headache and a sudden high fever, often exceeding 104 degrees Fahrenheit 40 degrees Celsius. This is accompanied by violent chills and general malaise. However, the defining clinical feature from which the disease derives its name is the mental state. The word typhus comes from the Greek typhos, meaning smoke or mist. This perfectly describes the profound stupor and delirium that descends upon the victim. As the bacteria attack the vascular system of the brain, the patient falls into a hazy, semi-conscious state. They may mutter incoherently, suffer from terrifying hallucinations, or stare blankly into space, unresponsive to stimuli. This typhoid state is a sign of severe encephalitis. Around the 5th day, the characteristic rash appears. Unlike the pustules of smallpox or the buboes of the plague, the typhus rash begins as small, pink macules on the trunk, spreading to the extremities but usually sparing the face, palms, and soles. As the disease progresses and the vascular damage worsens, these spots darken to a deep red or purple and become petechial, meaning they are the result of bleeding under the skin and do not blanch when pressed. In severe cases, large patches o. The mortality rate in the pre-antibiotic era was terrifying, ranging from 10% to 60%, but in the confined, malnourished populations of prisons and besieged cities, it was essentially a death sentence. The end usually came from vascular collapse, kidney failure, or secondary pneumonia. One of the most infamous historical examples of the disease's lethality is the Black Assize of Oxford in 1577. A prisoner named Roland Jenks was brought to trial in a crowded, unventilated courtroom. Although Jenks survived, the lice in his clothes, or perhaps the very air he breathed, thick with dried louse dust, infected the entire court. Within weeks, the judge, the sheriff, the jurors, and hundreds of spectators were dead. It was a stark demonstration that the diseases of the lowest dungeon could easily ascend to strike the highest magistrate. Medieval treatments were, as expected, ineffective and often exacerbated the condition. Physicians did not understand the vector, the louse, and instead blamed miasma or foul air. They attempted to clear the air with strong-smelling herbs like rue and rosemary, which judges would carry in small bouquets, nosegays, to ward off the stench of the prisoners, a feudal gesture against a louse-borne pathogen. Medical interventions included the standard, dangerous repertoire, bloodletting to reduce the fever, which only weakened the patient further, and administration of vinegar or mercury. Some physicians prescribed shaving the head and applying cooling poultices to treat the brain fever, which provided symptomatic relief but did nothing to stop the rickettsial infection destroying the blood vessels. Typhus remained the ultimate scourge of the unwashed. It was a disease that proved that hygiene was not merely a matter of comfort, but of survival. In a world where clothing was rarely changed and bathing was considered dangerous or sinful, the louse reigned supreme, and jail fever ensured that the sentence for even minor crimes was often death by delirium and vascular collapse. In the medieval landscape of mortality, where death was a constant companion to war and famine, there existed a singular, terrifying paradox located within the domestic sphere, the birthing chamber. Here, the biological imperative of creating life was inextricably linked to the immediate threat of ending it. While the knight feared the arrow and the peasant feared the famine, the woman feared the childbed fever. Known medically as puerperal fever, this disease was not merely an infection. It was a systematic, cascading failure of the female body, triggered by the very act of reproduction. It stood as a grim reaper at the foot of the birthing bed, claiming mothers just as they held their newborns. Unlike the indiscriminate slaughter of the plague, this was a targeted strike against women, a cruel evolutionary tax that turned the womb, the vessel of life, into a tomb of necrotic tissue. To understand the horror of puerperal fever in the Middle Ages is to understand a tragedy of ignorance, where the very individuals sworn to aid the mother, the midwives and physicians, were frequently the agents of her destruction, carrying death under their fingernails and in the fibers of their unwashed robes. To comprehend the ferocity of this disease, one must first analyze the physiological state of the postpartum body. Following the delivery of an infant, the female uterus undergoes a traumatic reconfiguration. The placenta, having nourished the fetus for months, detaches from the uterine wall. This separation leaves behind a raw, bleeding wound roughly the size of a dinner plate, approximately 2. The primary causative agent, unknown to the medieval mind but identified by modern science, was Streptococcus pyogenes, group of Streptococcus, along with other pathogens like Staphylococcus aureus and Escherichia coli. These bacteria are aggressive, flesh-eating organisms. In the pre-antibiotic era, once they colonized the raw surface of the placental site, there was virtually no physiological barrier to stop them. They did not just infect the surface. They invaded the deep tissue, turning the regenerative process of birth into a rapid, liquefying rot. The tragedy of puerperal fever lies in its transmission. It was rarely an autoinfection. It was almost exclusively introduced from the outside. The concept of asepsis or sterilization was non-existent. A medieval physician might arrive at a difficult birth directly from dressing the gangrenous wound of a soldier, lancing a boil, or even performing a dissection on a cadaver. There was no protocol for hand washing. The water used to wash the patient was often drawn from contaminated wells. The linens used to staunch the bleeding were reused, merely dried by the fire rather than boiled. Most lethally, the practice of manual examination, the insertion of fingers into the birth canal to check dilation or to manually extract a stuck placenta, acted as a direct inoculation. The physician's hands, teeming with microscopic colonies of virulent bacteria, were inserted directly into the open wound of the uterus. The very act meant to ensure the safety of the mother was the mechanism of her murder. This makes puerperal fever a uniquely haunting chapter in medical history, an iatrogenic, doctor-caused, plague. The incubation period was deceptively short, typically 24 to 72 hours. For the first day after birth, the mother might appear exhausted but stable. The relief of survival would settle over the household. But the bacteria were already multiplying exponentially within the uterine cavity. The first sign of the catastrophe was usually the rigor. It was not a simple shiver. It was a violent, uncontrollable shaking of the entire body, lasting for 30 minutes or more. The patient's teeth would chatter audibly, and the bed frame itself would rattle against the floor. This was the body's systemic reaction to the massive release of bacterial toxins into the bloodstream. Following the rigor, the temperature would spike dramatically, often exceeding 104 degrees Fahrenheit 40 degrees Celsius. The pulse would race, becoming thready and weak, beating over 120 times a minute as the heart struggled to pump blood through a system increasingly poisoned by sepsis. At this stage, medieval observers often misdiagnosed the condition. They called it milk fever, believing it was caused by the rush of milk to the breasts or the suppression of the lochia, the postpartum discharge. They believed the milk had wandered to the head or the womb, curdling and causing the heat. This fundamental misunderstanding of the etiology led to treatments that were useless at best and fatal at worst. By the fourth day, the infection would advance from simple endometritis, inflammation of the uterine lining, to fulminant sepsis. The uterus would fail to involute or shrink back to its normal size. Instead, it would remain large, boggy, and incredibly tender. The slightest touch to the lower abdomen would elicit screams of agony from the patient. The defining characteristic of the disease at this stage was the putrefaction of the lochia. Normally, the discharge after birth changes from red to pink to white. In puerperal fever, the discharge became scant, purulent, and turned a sickly greenish-gray color. The smell was the most horrifying aspect, a pungent, sweet, rotting odor of decaying meat. It was said that experienced midwives could diagnose the fever the moment they entered the house simply by the stench of gangrene emanating from the birthing bed. The bacteria were essentially digesting the reproductive organs while the patient was still alive. As the infection spread through the uterine wall, it reached the peritoneum, the membrane lining the abdominal cavity. This caused peritonitis. The abdomen would swell, becoming distended and rigid as a board, tympanitis. The intestines would become paralyzed, ileus, leading to severe vomiting of bile and fecal matter. The pain of peritonitis is considered one of the most intense forms of suffering a human can endure. The patient would lie perfectly still, knees drawn up, terrified to take a deep breath because the movement of the diaphragm caused excruciating pain in the inflamed abdomen. As the bacterial toxins flooded the brain, the septic delirium set in. The mother, previously lucid, would begin to mutter incessantly. She might pick at the bedclothes, carphalogia, a classic sign of impending death, or hallucinate that her baby was being stolen by demons. The facies hippocratica would appear. The face became pale and pinched, the eyes sunken and glazed, the nose sharp, and the skin cold and clammy despite the internal fire. In the final hours, the body would surrender. Metastatic abscesses might appear in the joints, filling the knees or elbows with pus. The lungs might fill with fluid, pulmonary edema. The end usually came via septic shock. The blood pressure plummeted, the organs shut down one by one, and the patient slipped into a coma before cardiac arrest. The tragedy was often compounded by the survival of the infant, who would now be left motherless in a world where wet nurses were expensive and bottle feeding was a death sentence. The medical response to puerperal fever was a catalogue of horrors, driven by the humoral theory. Physicians believed the womb was a sewer that needed to be purged of retained, corrupt fluids. Intrauterine fumigation. This was a standard, agonizing practice. A funnel was inserted into the birth canal, connected to a pot of burning substances. Physicians used aromatic herbs to sweeten the womb or, more often, foul substances like burning hair, feathers, or sulfur to shock the womb into expelling the retained placenta or humors. This introduced heat and smoke directly to the inflamed, necrotic tissue, causing immense pain and further drying out the protective mucous membranes. The pessaries of doom. Cloths soaked in mixtures of vinegar, honey, oil, and sometimes mercury or arsenic were inserted into the vagina to cleanse the area. These unsterile foreign objects acted as perfect wicks, drawing more bacteria deep into the uterus. Aggressive phlebotomy, operating on the belief that the fever was a sign of plethora, excess blood, physicians would bleed the patient. For a woman who had just lost significant blood during labor, removing another pint of blood was a physiological catastrophe. It stripped the body of the very iron and oxygen-carrying capacity needed to fight the infection, accelerating the descent into shock. Cupping and blistering. Hot cups were applied to the abdomen or thighs to draw the bad humors away from the center. Blistering agents, cantharides/Spanish fly, were applied to the skin to create raw, weeping wounds, believing the pus draining from the skin was the sickness leaving the body. This only added superficial torture to deep internal agony. Beyond the physical pain, the woman suffering from childbed fever faced a spiritual crisis. In the medieval mindset, a woman who had just given birth was considered religiously unclean until she had undergone the ritual of churching, purification, roughly 40 days after birth. Dying during this limbo period was a source of profound anxiety. There was a fear that her soul was vulnerable. Priests would be summoned to perform emergency rites, often in a room thick with the miasma of sickness. The fear of childbed fever permeated the female experience. Women wrote their wills as soon as they realized they were pregnant. They knew that the bed of triumph could instantly turn into a deathbed. The sheer randomness of the disease, striking the queen in her silk sheets as often as the peasant in the straw, reinforced the medieval view of death as an arbitrary, divine lottery. Puerperal fever remains one of the darkest chapters in the history of human suffering because it was a tragedy of proximity. The killer was not a rat, a flea, or a miasma cloud. It was the touch of the helper. It was a massacre of mothers facilitated by the silence of the microscopic world, a biological injustice that turned the moment of greatest joy into a week of agonizing, putrid decay. As the medieval era waned and the Renaissance began, humanity believed it had catalogued all the ways it could die. They knew the plague, the leprosy, and the flux. But in 1495, during the Siege of Naples, a new, biological horror erupted that defied all medical understanding. It was a disease of Venus, transmitted not by breath or rats, but by the most intimate act of human connection. Initially, it had no name. The French called it the Neapolitan disease, the Italians called it the French disease, and the English eventually settled on the Great Pox to distinguish it from smallpox. It was syphilis caused by the spirochete bacterium Treponema pallidum. Unlike the modern version of the disease, which is a slow, chronic burn, the syphilis of the late 15th century was an explosive, virulent wildfire. It struck with a ferocity that suggests a population completely immunologically naive, tearing through Europe with a speed and cruelty that rivaled the Black Death. The clinical manifestation of this great pox was far more grotesque than the clinical syphilis we know today. Contemporary chroniclers described symptoms that sound like the work of a sadist. The disease began with genital chancres, but quickly evolved into a generalized pustular rash covering the entire body, from the scalp to the soles of the feet. These were not simple sores. They were often described as gummata, large, rubbery, ulcerating tumors that could appear anywhere on the skin or inside the organs. The bacteria had a particular predilection for the skeletal structure and the face. It ate away the flesh, exposing the bone beneath. A specific, horrifying deformity became the hallmark of the syphilitic, the destruction of the nasal cartilage. The bridge of the nose would rot and collapse, leaving a gaping, dark cavity in the center of the face, known medically as the saddle nose deformity. To hide this shame, a grim industry of false noses made of silver, ceramic, or wax emerged, but nothing could mask the smell of necrosis that clung to the victim. In severe cases, the disease caused what was known as the grand gore. The flesh would literally fall off the body in chunks. Patients were described as rotting alive, emitting a stench so foul that even their own families could not bear to approach them. The pain in the bones, particularly at night, was described as if the limbs were being twisted by iron vices or chewed by dogs from the inside, denying the sufferer even the mercy of sleep. If the disease was hell, the cure was purgatory. Medieval and Renaissance medicine, grasping for a solution to this wet, putrid disease, turned to the driest, most caustic agent they knew, mercury, also known as quicksilver. The prevailing medical maxim became, "One night with Venus, a lifetime with Mercury." Mercury was applied in every conceivable way. It was rubbed into the open sores as an ointment, administered orally as pills, or used in fumigation cabinets. In these cabinets, the patient sat naked over a pot of heated mercury, breathing in the toxic vapors while sweating profusely. The logic was to sweat out the poison, but the reality was a heavy metal intoxication that destroyed the body faster than the syphilis. The side effects of the cure were often indistinguishable from the disease itself. Mercury poisoning or hydrargyria set in rapidly. The patient's gums would ulcerate and turn blue. Their teeth would loosen and fall out. They produced pints of saliva a day, drooling uncontrollably, a process physicians wrongly believed was the body expelling the syphilitic poison. In reality, it was heavy metal toxicity destroying the nervous system. Tremors, madness, and kidney failure followed. Many patients died not from the spirochete, but from the liquid metal poured into their bodies by their doctors. Syphilis changed the social landscape of Europe forever. It introduced a new element to human interaction: terror of intimacy. The disease became a mark of moral failing, a divine punishment for lust. Public bathhouses, once the center of social life in medieval cities, were boarded up and closed down forever, as they were seen as breeding grounds for the pox. The communal cup, the friendly kiss of greeting, and the sharing of beds in inns were all viewed with deep suspicion. It taught humanity that danger lurked not just in the cold wind or the rat-infested alley, but in the embrace of a lover. We have now journeyed through the darkest corridors of human history. We have walked the plague-ridden streets of London, stood in the leper colonies where the living were declared dead, and watched the flicker of St. Anthony's fire consume limbs. We have witnessed the desperation of the Red Cure, the agony of the bloody flux, and the tragedy of the childbed fever. We have seen humanity at its most vulnerable, besieged by microscopic predators they could neither see nor understand, fighting a losing war with prayers, bloodletting, and mercury. These stories are the collective scars of our species. They are the reality of a world without antibiotics, without anesthesia, without vaccines, and without the germ theory. But now the screen fades to black. The screams of the surgery room silence. The tolling of the death bell stops. The heavy, rotting smell of the medieval city dissipates. You are here now. Take a deep breath. Feel the clean, cool air filling your lungs, lungs free of tuberculosis. Feel the warmth of your blanket, a bed free of lice and fleas. You are safe. The monsters we described are no longer hiding in the dark corners of your room. They are trapped behind the glass of microscope slides and the pages of history books. The night outside is quiet. The terror is over. Science has built a fortress around you. Close your eyes, sink into the comfort of your modern sanctuary, and sleep with the profound peace of knowing that those dark days are gone, and you are safe, warm, and alive.